So good evening, everyone. I recognize many faces here. Good to see everyone. So my talk is predominantly about surgery, obviously, but we do have a little bit on the incidence as well. These are similar numbers to Teresa. So about 7,300 Canadians are diagnosed with melanoma per year, and about 1,250 die from melanoma. When we look at Ontario specifically, this is data from Ontario. It is the entire population of patients in Ontario with melanoma, and in between 2003 and 2012. And we can look at what's happening with the incidence of melanoma. And you can see that the incidence is generally increasing for patients that are over the age of 50. So the younger patients kind of are down here, and then we have the 40 to 59-year-olds here, and then 60 and above, and then the older patients over 80 years old. But you can see the general trend here in Ontario is that the incidence of melanoma, as Teresa already mentioned, is increasing. So skipping right on to surgical treatment. So as many of you already know, there are two parts to the surgical initial treatment generally in patients who are clinically node negative, meaning that when you come to see us in clinic, I can't feel anything in your armpit or your groin or head and neck. So we have the wide local excision and we have the sentinel node biopsy. And really most of the research in the last probably 10, 15 years has been on the sentinel nodes. But there's a little bit of work going on in margins as well. So as you're aware, the whole purpose of taking a wider margin around your melanoma is to decrease local recurrence. And in the past, we used to take 5-centimeter margins on either side of the melanoma so that you would have a 10-centimeter defect, which, as you're aware, is pretty big, and that would be difficult to close, and a lot of people had skin grafts. And over time, that has decreased. And it's decreased the margins have decreased, and we've done it safely as well. We now know that the recurrence rates from the wide local excision, looking at studies that range from 5 to 16 years of follow-up, that the recurrence rate at the wide local excision is about 5% or less. So it's really quite low. We have updated our margins recommendations from Ontario. I co-chair the Program in Evidence-Based Medicine Melanoma Disease Site Group, and we've updated the margins and the lymph node guidelines recently. And what you can see here is for melanoma in situ, so a pre-malignant melanoma, we do a 5 to 10 millimeter margin. For melanomas less than a millimeter, a 1 centimeter. For 1 to 2, kind of 1 to 2 centimeters, where if you can, do a 2 centimeter. And then for anything greater than 2 millimeters in depth, we do a 2 centimeter margin. And of course, when we do this, we're just taking skin and subcutaneous tissue. We are not taking out muscle, so it really should not, in the long term, affect people's long-term function. We are looking at trying to do an international trial. Sunnybrook participated in a pilot study looking at comparing a 1 versus 2 centimeter margin, really for anyone with a melanoma greater than a millimeter in depth. We had support from Annette from the Melanoma Network of Canada. We had support from Teresa through the clinical trials group in Canada. But this is hopefully going to get funded, and we're doing this in conjunction with the Australians and the Europeans because we do need about 3,000 patients to answer this question. But what we're hoping for is to make that margin even less in the future so that we're doing a 1 centimeter margin rather than a 2, which really will get people to recover faster, and then hopefully they can get onto their systemic therapy faster. So onto lymph node staging and treatment, which has really been the area with the most change. These are very useful numbers for people in clinic, I find. So what is the likelihood when someone is clinically node negative in clinic? What is their likelihood of having disease in their lymph nodes? So we know that overall, if your melanoma is less than a millimeter in depth, that overall likelihood is about 5%. If your melanoma is less than 0.8 millimeters, so really very thin, it's about 2 to 3%, so we tend to not offer those patients a sentinel node biopsy. But if your melanoma is between 0.8 and a millimeter, we'll start having that conversation, and your likelihood of the melanoma spreading from the primary site to the lymph nodes when it's that thin is about 9%. And so we have a discussion about that, whether someone wants to go ahead with that. And my prediction is, with, again, the additional adjuvant therapies coming forward and the fact that you'll see later on in the talk we're doing completion dissections less, is that we'll probably be doing this more frequently for people. Once the melanoma gets greater than a millimeter in depth, you're starting to get to higher likelihoods of the lymph nodes being involved. So between 1 and 4 millimeters in depth, you're looking at about a 20% chance of the lymph nodes being involved. And then once you get greater than 4 millimeters in depth, then you're looking at about a 40% chance of lymph node involvement. So this was our first major study looking at lymph nodes. And this is the study that really showed us that doing the sentinel node biopsy improved outcomes for patients. It gives us staging information, prognostic information, and of course the adjuvant. It indicates which patients would benefit from adjuvant therapies. So this study was completed in the 2000s. So again, all of this is really very recent. It took patients between 1.2 and 3.5 millimeters in depth, and they were randomized, so flip of the coin. They were randomized to either just the wide local excision alone, or they got the wide local excision and sentinel node biopsy. If the sentinel node biopsy was negative, great, you're done. If it was positive, patients went on to have all of their lymph nodes removed in that basin. So if it was a positive axillary sentinel node, they got an axillary dissection. If it was a positive groin node or head and neck, they had a groin or head and neck dissection. In the watch and wait group, the patients who did not have the sentinel node biopsy, those patients, about 20% of them developed palpable lymphadenopathy, and at that time, they went on to have a full dissection. So we now have 10-year follow-up from this study. It was initially reported in 2006 and then re-reported in 2014. And you can see that the nodal positivity rates are quite similar in the two arms. So in the sentinel node arm, about 22% of patients had positive nodes. And in the observation arm, it was about 20%. When you look at the melanoma-specific survival, if you had disease that was taken out that was microscopic, your 10-year survival, again, remember, no adjuvant therapy in this study because it's too old for that, the 10-year survival was about 60%. Versus about 40% if you develop palpable disease. So what this study showed was that it's better to take out disease when it's small and microscopic rather than leaving it there and developing big lymph nodes that we then have to take out. And it was a pretty big study. There were about 1,350 patients in it. So this was the study that really defined that patients with clinically node-negative melanoma should have a sentinel node biopsy as part of their care. The next two studies, I have so many fewer studies than Teresa. This will be so much quicker. But there are two more studies that we'll talk about with positive sentinel nodes. So the next question was, okay, we've got a positive sentinel node. What do we do now? Do we need to do that full dissection? Because that full dissection, as many people in the room may be aware, has a lot of side effects associated with it. And later on this evening, we're going to be hearing about lymphedema, which of course is one of the main side effects from having a dissection. So the next, there were two international studies looking at whether we needed to do that completion dissection for patients after a positive sentinel node. So there was a German study, again, published in 2016, so very recent. This took patients who were between 18 and 75 years old. Patients had melanoma on their arms or legs or trunk. It had no patients with melanoma of the head and neck. and patients had to have micrometastases in their sentinel nodes, so really very small amounts of disease. And the reason why this was the inclusion criteria was because people were quite worried about not doing the completion dissection. So these were all the exclusions. And then there was fairly intense follow-up for these patients. And remember, it's a German study, so they do things slightly differently than we do in North America. So every 3 months, there was a physical exam. They also did blood work, which we do not do in North America or really many other places. They had lymph node an ultrasound of their lymph node basin that was involved. And then they also had CT scanning or PET scans every 6 months for 3 years. So a very intensive follow-up regime. If they had the surgery, they just had the completion dissection, and this study reported at 3 years. They will, of course, do 5-year and 10-year follow-up, but this is the 3-year data. This is the flow of the study. It's hard to read, so I apologize, but essentially at the bottom, they had about 230 patients in either arm, so it's a smaller study. And when you look at the outcomes, if you just concentrate on this graph here, you can see that the patients who had surgery and the patients who didn't have surgery essentially have the same overall survival. Again, remember this is at 3 years, but it's the same overall survival. And really, the number of local recurrences is much less than the patients who had distant recurrences, suggesting that really taking out the rest of the lymph nodes doesn't seem to change the progress of the disease for these particular patients. And again, this is where we're hoping that the adjuvant therapy will help decrease the number of distant recurrences, but certainly the surgery did not seem to help. So MSLT2 was the second study that looked at this question. This was an international trial as well. We participated in this trial. And it took patients who had a positive sentinel node, randomized them to either a completion lymph node dissection or to ultrasound monitoring. Patients, again, 18 to 75 years old, mainly because they wanted to have 10-year follow-up. And patients could have any amount of disease in their lymph nodes. And the ultrasound monitoring was every 4 months for 2 years, and then every 6 months out to 5 years, and then just clinical follow-up out to 10 years. If a lymph node was abnormal on the ultrasound, then the radiologists went back and biopsied it. The patient had a repeat metastatic workup to see what was going on elsewhere in the body. And if there was no metastatic disease, then the patient went on to a completion dissection at that point. And the surgery was pretty well defined in this study. And then after the surgery, it was the same follow-up. So this study accrued for 10 years, between 2004 and 2014. It was initially published with 3 years of follow-up in 2017. It was like June of 2017, so like really just more than a year ago. 42% of the patients were female, as you would expect. Males tend to present with more advanced disease. Median age was young, 52 to 53. And the majority of patients had truncal and extremity melanomas, although there were some patients with head and neck melanoma. The median depth was 2.1 millimeters. So in this study, similar to the German study, most patients had a low volume of disease in their sentinel nodes. So they had one sentinel node that was positive. The amount of disease in their lymph nodes was low. It was around 1 millimeter or so. Again, kind of reflecting the bias of the surgeons. They didn't want to put patients with a lot of disease there because they didn't want to kind of do harm to patients either. And again here, about 8% of patients had adjuvant therapy, which was a mix, but predominantly interferon. This is, again, hard to read, but it's just showing that the amount of disease in the lymph nodes was small. It was predominantly microscopic. And what they found in this study was that over time, about 25% of patients in the observation group did develop palpable nodal disease, which is about what we expected. But it does mean that if someone is going to go on ultrasound monitoring, that they do need to make sure they follow up with their ultrasound monitoring protocol. But again, similar to the German study, you can look at the melanoma-specific survival here, and there is no difference between the surgery arm and the observation arm. So again, supporting that we probably do not need to do a completion dissection as a routine thing for patients after a positive sentinel node, which is a big change in practice. We looked at prognostic factors, and they were kind of the ones that you would expect. So looking at what affected survival. So a deeper melanoma, an ulcerated melanoma, and then if you did have non-sentinel nodes that were positive, so if you did have the completion dissection and there was disease in those lymph nodes, those patients as well tended to not do as well. So the big question is, do any patients benefit from a completion dissection? In both of the studies, patients with low volume disease were put into the studies. And this is a plot that looks at a whole bunch of factors, and it looks at whether it favors a completion dissection or observation. This line down the middle is kind of where it doesn't make any difference. And if these factors here cross the midline, it means it doesn't make any difference whether you had surgery or not. And you can see that really nothing favors a completion dissection. Even when we looked at when patients had larger amounts of disease in their lymph nodes, or if they had multiple number of nodes involved, none of those factors affected whether that patient would benefit from a completion dissection. So we've just updated the Ontario guideline on this, and the Ontario guideline is that essentially any patient with a positive sentinel node should be considered for ultrasound monitoring. And this, again, is just looking at recurrence in the nodes, and generally few patients had isolated nodal recurrence. Patients tended to recur with both distant and local, so again, emphasizing the need for the adjuvant therapy for many of these patients. We did look at some quality of life outcomes, and in the completion dissection arm, about 25% of patients had lymphedema. I would say in my practice that is unfortunately higher. In the observation arm, these are the patients who just had a sentinel node biopsy. It's about 6%. And I mean, this to me is a very big impetus to not to do completion dissections on people. Lymphedema is when your arm or your leg swells as a result of having all your lymph nodes removed. Thank you for clarifying. So this is kind of the last bit of the presentation. This is now talking about patients who come in with disease that you can feel in their lymph nodes, so they have palpable disease. And so what do we do for these patients? We do a biopsy, we obtain the molecular markers that Dr. Petrella was talking about, the BRAF, the NRAS, and the c-KIT. We do a metastatic workup. And now what we're looking at is these patients will need surgery, but we're looking at potentially using these markers to shrink down the tumor preoperatively. So if someone is BRAF positive, and as Dr. Petrella said, that mutation is in about 40% of patients, we will use the dabrafenib and the trametinib preoperatively. Right now we're doing this as a trial. There's been one study published on this, but we will use that drug to shrink down the tumor, make the surgery easier, get the patient onto systemic therapy sooner, and try to improve outcomes there. So right now we have nearly done our trial, and essentially what we're doing is for patients who are BRAF positive, they go on drug for 4 months, then they have surgery, and then they get 8 months of further treatment. And what we've found, that this has been quite successful. We've had no patients who've progressed on the treatment while they're on drug, which is excellent. And again, as Teresa's already mentioned, the patients who tend to respond very well and have a complete response to the medication tend to do very well in the long term. So this is just a CT scan. This is kind of right at the level of the pelvis, and you can see a big lymph node here, and then 4 months later that lymph node is this big, and so that patient went on to surgery and is continuing to do well. So there's one study published on this in 2018. I'm not going to go through this in too much detail, but they essentially took a very similar group of patients. They were either stage 3 or stage 4 patients who could have all of their disease resected. In this study, patients were randomized either to drug or to surgery, and then they were followed afterwards. This study stopped very early at 7 months. And the reason for that was the patients who went directly to surgery tended not to do so well. So the Study Disease Monitoring Board said that we should stop the study. But what they found was in the patients who went to surgery, first of all, they had an event, or they had a recurrence of some sort within 3 months of the surgery, whereas the patients who had the drugs first and then went on to surgery afterwards, they had a recurrence at around 20 months, if they were going to recur at all. So this was really the first study looking at using some of the drugs that Dr. Petrella talked about preoperatively, and then operating on these patients. And what they also found similar was about 50 or 68% of patients had a complete response to disease, meaning that when they went to operate, even though it felt like there was disease still there, when the pathologist looked under the microscope, all they saw were dead cells. So they had essentially got rid of all of the cancer. And this just shows the curves, and you can see that they're very different here. This is the group that got the medication. This is the group that did not. And this is the overall survival. So kind of in summary, I think we will be doing more sentinel node surgery, especially on the older patients and in patients with thinner melanomas between 0.8 and 1, partially because of the survival benefit, but also finding out who would benefit from adjuvant therapies. I think we should anticipate less secondary nodal surgery, so fewer completion lymph node dissections. But patients, if you're going to go down this route, patients will need to be clearly monitored and on an ongoing basis. And then I think eventually this will be putting all patients who are BRAF positive, and if they have palpable disease, I think they'll go on neoadjuvant treatment up front and then have surgery. Thank you. And then that's where our guidelines are. So I don't operate in the GI tract, but in general, if we're thinking of operating for metastatic disease, it tends to be if it's an isolated lesion, meaning if it's the only spot, and then we might consider it. But we may also consider doing radiation to that area, or we may consider carrying on with or starting systemic therapy. So when we're operating on patients with metastatic disease, that tends to be a discussion in our multidisciplinary cancer conferences or our tumor boards to make sure that that's the right decision for a patient. So we don't do routine blood tests in North America for monitoring for tumor markers for melanoma. They're kind of 50-50 accurate, and we do not use them routinely. So that may be for a different reason. I don't know particularly. That may be to check your kidneys just to make sure that the kidneys can manage a CT scan and the dye.